again, thanks to everybody who has decided to attend this session. I'm excited to have you, and I'll just get started with saying that what we'll talk about today, I'll give a really brief history of medical cannabis use. I'll talk a little bit about whether it works, and if so, what does it work for? A little bit about the pros and cons of forms of use, and reasons to maybe not use it, possible adverse effects, and then kind of a wrap up and some questions. So I may go kind of quickly through some of the slides, but I know that I want to have plenty of time for people who have questions. So if I'm a little quick, I think we're recording and you may be able to watch it later and take a look at the slides. So first, I just want to talk about what cannabis is. Cannabis is actually a plant that comes from the Cannabaceae family, which also happens to include a familiar plant, which is hops. We grow hops in the Pacific Northwest, and most of you guys are probably aware that hops form an important ingredient in beer. And as you also probably are aware, cannabis has a lot of different names, a lot of different nicknames, but none of those are the actual plant name or the official botanical name. So by any other name, cannabis is still cannabis. So a quick history tour. Medicinal use of cannabis was occurring before written history, which has been uncovered in archaeological digs. And the earliest written history was over 3,500 years ago in Egypt. Egyptian writings showed that cannabis was used for medicine at that time, as well as in first and second century China. There's writings indicating its use as a medicinal product at that time. It was first introduced to modern Western medicine in the 1840s when a physician, Dr. William O'Shaughnessy, found that it worked very well to palliate certain symptoms of rabies, of all things, and then was utilized in Western medicine for quite some time until the U.S. taxed it so heavily in 1937 that essentially people couldn't get access to it because of the financial burden of that. And then later on in 1970, it attained what's called a Schedule I classification, which indicates that it's considered to be at high risk for abuse with no accepted medical use. So what's special about cannabis, first of all, to understand that is you need to have a little bit of a very basic understanding of what's called the endocannabinoid system. So endo refers to internal to our bodies is what that refers to in this terminology. And cannabinoid is a term for chemical products that are found both in cannabis but also in our bodies. And so that system includes receptors. The most well-known are CB1 and CB2 receptors, CB1 being found primarily in the nervous system and CB2 primarily in immune cells. And then there's endocannabinoids, which are internally to our body produced chemicals that actually look very similar to chemicals in the cannabis plant. The two here in the center, anandamide and 2-AG, are the two that we make. And then there are also enzymes that our body makes that regulate the production of these things, of these two endocannabinoids. So what happens here is that cannabinoids found in the cannabis plant actually interact with this internal system that we have. And that's why we have this relationship and use cannabis for various things, recreation, medicine, etc. So what's so special about it are those phytocannabinoids. Phyto refers to, is Latin for plant. So the term phytocannabinoids is referring to cannabinoid substances that are made in plants. And the term or the definition, any plant-derived natural product capable of either directly interacting with cannabinoid receptors in our body or sharing a chemical similarity with cannabinoids that we actually produce internally, or both of those features. And there are over 110 cannabinoids in cannabis, in the cannabis plant, that are very similar chemically to the cannabinoids that we produce in our bodies. And some of the properties of cannabinoids include pain relief, anxiety relief, anti-seizure properties, anti-nausea properties, anti-inflammatory, antioxidant, anti-tumor, and a protective effect of neural tissue or nervous system tissue, and lots of others purportedly as well. So I'd like to mention first the most studied cannabinoids. And so the first one of these is THC. And THC has strong activity at the CB1 receptors in the nervous system, and very weak activity at the immune receptors. Major effects, of course, we're very familiar or have heard of the psychoactive effects. These are the effects that kind of can give us things like hallucinations or anxiety from its use, or euphoria, or just that high feeling. But also THC is known for its anti-nausea effect, pain relieving effect, reducing spasms, particularly in people who have diseases that cause spasm, and being an anti-inflammatory. And there are some associated prescription drugs with THC. So Marinol or Dronabinol is a legal prescription drug approved by the FDA in the United States that is a synthetic THC. Sesamet or Nabilone is also a THC-based legal prescription drug in the United States. Sativex or nabiximols is a drug that's not legal in the US, but is legal in over 30 countries and also in Canada for some specific symptoms and issues. And then levonorgestrel is a product that never actually came to fruition as a prescription medicine anywhere, but was used in research. And it's what we would call a THC analog or a similar chemical entity. And then CBD has very weak activity at the nervous system and immune cell receptors, but also has the effect potentially of pain relief, protection of nervous tissue, anti-seizure activity is what it's best known for, also anti-anxiety, anti-nausea effects. And what you see here is that when we look at the associated prescription drugs, is that Epidiolex is a fairly recently approved prescription drug containing pure CBD, plant-based CBD, and it's primarily used for certain seizure syndromes present in children that are not able to be treated in any other way. And then Sativex, as you see, again on the list here. And so what this tells you is that the Sativex has both THC and CBD in it. And again, it's not something that's been approved in the US for any particular application yet, but over 30 countries, particularly European countries and also Canada, use it. It was first produced or used for the spasms and pain experienced by people who have MS. That's what it was originally produced for and approved for in all of those countries. And then the Sativex was approved also fairly recently, in recent years, in Canada for the use of cancer pain that has not been able to be managed with other traditional medications. So there's other compounds in terpenoids, in cannabis called the terpenoids. And these are the volatile organic compounds that are responsible for the smell, and some people would say the flavor of cannabis. And they are present in very small amounts, but even in small amounts, they actually have effects on our bodies. And so some of those terpenoids include these various ones: limonene, myrcene, pinene, linalool, the caryophyllins. There's a couple of different caryophyllins, nerolidol, and phytol. And I think it's worth pointing out that these terpenoids are also present in other botanical things. So for example, you've got a couple of clues here with the pictures, but limonene is also found in the rind of lemons. Pinene is found in pine tree, and linalool is something that happens to be found in the lavender plant. So myrcene, I don't have a picture of hops up here, but myrcene is also found in the hops plant. So terpenoids are found in a wide variety of both food and floral and other types of plants. And they also have quite a few effects on the body. So terpenoids can be anti-anxiety, anticonvulsant, antidepressant, and sedative, as well as anti-inflammatory. They can be bronchodilatory or opening up the lung tissue, or antifungal or antiprotozoal in the event that we had those types of infections. So those are some of the effects of terpenoids, even in very small quantity. So the presence of cannabinoids and terpenoids together in the cannabis plant is what is thought to be responsible for what's called the entourage effect, which is the effect of both of these taken together being stronger than either one of them taken alone. And so this is the reason that a lot of people are proponents of whole cannabis as a medical product, or having the availability of whole cannabis to be used for medical purposes. So I want to mention a couple of noted, as we might call, entourage effects. So for example, when THC and CBD are present in a cannabis product at nearly equal quantities in a 1-to-1 ratio, say 1 milligram of THC for every 1 milligram of CBD, that would be an entourage effect, or an effect where the two of them together work a little bit better than one of them alone. And when they are together, you have a reduction in the anxiety that can occur with the use of THC by itself, and a reduction in the memory issues that some people experience from THC, the short-term memory lapses that occur when people are using THC, whether recreationally or for medical purposes. And the two of them together may actually increase the pain control that might be seen with either one of them separately. So that would be an entourage effect of THC and CBD together. And as far as the terpenoids, you get some entourage effects as well from the caryophyllene presence. When caryophyllene is present in cannabis, you get a decrease in pain and inflammation, decrease in both of those things. It's a stronger effect than just the THC or the CBD by itself. You also see a decrease in anxiety when cannabinoid products contain considerable amounts of linalool or limonene. When you have quite a lot of myrcene terpenoid in cannabinoid products, that tends to be very sedating and may also help reduce pain even further. And then the pinene, when there's a fair amount of pinene present, you get a reduction in, again, the memory issues that people sometimes have, the short-term memory deficit when using cannabis. So to talk for just a moment about nomenclature, or what's in a name, a lot of people talk about, when they talk about cannabis, they talk about cannabis indica or cannabis sativa, or they have all these strain names like blueberry kush, or things that refer to lemons or mangoes, or that type of thing, blackberries. That used to be how we could try to identify the different effects of different varieties of cannabis. But nowadays, what we're talking about and trying to get people to use as new lingo is chemovars. And what that stands for is chemical variety. And that's because different, if you will, strains of the plant will contain different quantities of both cannabinoids and terpenoids. So the researchers who've been looking at cannabis and its effects on the body for many, many years talk about three types, major types. Type 1, where THC is the predominant cannabinoid. Type 2, where you have near equal quantities of THC and CBD in the plant. And then type 3, where you have CBD as the predominant cannabinoid. And then you can additionally distinguish how the plant might affect the body depending on that terpenoid profile. So as we mentioned, if you had a cannabinoid product that had a lot of myrcene, you would know that it was more of a sedating product. And this is just to show you very quickly that there are companies that analyze the terpenoid content of cannabis or cannabinoid products. And so, for example, you see that this one has a lot of the limonene, which we saw might help reduce anxiety. Limonene also is thought to have a lifting effect, lifting of the mood. And then quite a bit of the beta caryophyllene, which was thought to help reduce pain. And then the next one would be a fair amount of myrcene. So this could be somewhat sedating if you understood those different effects of those terpenoids. So in reviewing evidence, actual research-based clinical evidence of how cannabinoids work and whether they work, the available research studies that we have typically include synthetic THC products, such as the dronabinol and the nabilone. They will also sometimes include products that are the extracted THC, either with or without CBD, and that's extracted directly from the plant, so not synthetic. And much less often, research studies have used whole cannabis in some form as the research product of choice. So as we talk about the evidence around the use of cannabis for what I hear cancer patients often say they're interested in using it for, we won't often be looking at studies that are looking at just whole cannabis. So oftentimes, what I'm talking about are the symptoms that most people tell me they have an interest in using cannabis for. So I'm going to go through some of those, and many of them are treatment related. So nausea and vomiting being a primary one. And what you see here is some different either studies or reviews of studies and the type of cannabinoids that were looked at. And so as you look down through here, what you see is that all of these cannabinoids in the table are ones that were the synthetic or the research-based cannabinoids. And then there's control of, sometimes they're looked at against traditional anti-nausea meds, sometimes they're looked at against a placebo, which wouldn't have any, we wouldn't expect to have any type of effect. And then specifically, we do have one study that was looked at with the dronabinol or the synthetic THC against ondansetron, one of the most common anti-nausea medicines. But what you basically see here is that the cannabinoids were more effective than some of the traditional medications and preferred by patients. So again, dronabinol decreased nausea in this group of studies and was preferred. Decreased nausea was preferred. And then specifically when we looked at it against ondansetron, one of the most common medications given, the ondansetron, it was slightly more effective than the ondansetron and certainly quite a bit more effective than placebo. So basically, you know, cannabis may be very helpful in controlling nausea and vomiting, which people have during treatment, and sometimes even after treatment, they can deal with that for quite a while. Appetite and taste and smell are other reasons that I often hear patients wanting to use cannabis. I should give you the disclaimer that I mostly focus on nutrition-related effects, and there may be other studies that look at things like sleep or anxiety or you know, relaxation and things like that. So I didn't necessarily go into that very much here, but again, I'm looking mostly at the nutrition-related effects of having cancer or being getting cancer treatment. So cannabinoids that have been studied include dronabinol against this is a little bit of an error, I apologize, against megase or megestrol acetate, which would be which would sort of be the control, but it was actually really just comparing two things that that are known to potentially improve appetite. And megase is something that can be prescribed to improve appetite. And so when this was reviewed, what was seen was that the megase was quite a bit more effective than the dronabinol or the synthetic THC. And it's worthy of note that this particular study was in patients with advanced forms of cancer. In another study, THC with CBD together or THC by itself against a placebo, so something that was expected to have no effect, there was no difference. But it's also worthy of note that this was a very low dose at 2.5 milligrams only. And then finally, THC versus a placebo. This was for taste and smell specifically. So it did appear in this very, very small study of only 11 people, it was a pilot study, that THC seemed to improve what's called the chemical sensory response, the ability to perceive taste or smell, was more than twice as effective as the placebo, quite a bit more effective in terms of improving the taste of food, and the appetite score was better than with the placebo. This type of study, though, because it had only 11 people, is something that really needs to be repeated so that we can get a good feeling of whether this would be a viable solution for some people, and there's good evidence behind it. Another reason I hear patients wanting to use cannabis is pain. This is one of the top things that a lot of people are interested is pain or neuropathy. And so this is just a listing of several reviews looking at various studies. And what you see is the cannabinoids were mixed. So this would either be synthetic or extracted THC with or without CBD. And then one group of studies actually looked at whole cannabis. So we'll talk about that in a moment. But what you see here is that cannabis in one set of reviewed studies was more effective than placebo. In another set of reviewed studies, 15 of 18 trials showed a significant but modest effect of cannabinoids against pain. This was either against placebo or an active control, meaning a medication expected to improve pain. And one of the things you saw here was that nobody dropped out of the study and there were no severe adverse effects. Now, the first set of studies the authors did feel that there were significant adverse effects. But worth noting that when people don't drop out of the study, and so with a lot of opiate studies, up to 30% of patients will drop out of studies using opiates for pain control because they don't like the effects of the opiates. In a third set of reviews looking at cancer and other types of pain, 27 of 38 what we call gold standard type of studies, randomized controlled trials, showed a significant pain relief with cannabinoids against either placebo or active control. And then finally, if we look at cannabis for neuropathic pain, more very specifically, 6 randomized controlled trials, all 6 showed significant relief, but 3 studies, and that would be statistically significant, but 3 studies showed what's considered to be clinically meaningful relief. And the definition of that was that the effect had to be more than twice as much as the placebo. So as you see the comparison here, placebo 18, 45% though for the cannabinoids, 24% versus 53 and 26 of the placebo versus 61% of patients for the cannabinoids. So considerable clinically meaningful relief with whole cannabis for neuropathic pain. So this is a slightly different kind of study, and this is results from what's called an observational study. Over 131 patients agreed to participate in this study where they rated various symptoms prior to the use of medical cannabis, and then after 6 to 8 weeks of medical cannabis use. But the key difference here with all the other studies that we just looked at is that they're doing what's called self-titrating their dose, which means they're basically utilizing an amount of cannabis that for them as an individual helps to reduce the effects and to an amount that they can tolerate the side effects of the cannabis, and that might be the psychoactive effects that you would experience. So there was no set dose like in most of the other studies. It was just up to them to figure out what amount worked for them. And what you see is that in each one of these cases, nausea, vomiting, anorexia, or poor appetite, weight loss, and pain, or excuse me, we'll start with the first few. The number of people with moderate amounts of these symptoms went down almost the same amount, if not the same amount, as the number of people who had none, meaning they switched from having moderate symptoms, essentially, to having no symptoms. And then very few people actually had an increase in their symptoms, as you see in the severe. So you had a decrease of 38% of people having moderate, decrease of 23% of people having moderate in the vomiting, decrease in 38% of people having moderate anorexia, and the number of people, of course, having none of these symptoms went up the same amount. So what that suggests is that this was statistically significant for a trend toward improvement for all the symptoms that were studied. And then when it came to pain, what you saw is that there wasn't much of a difference for people with moderate pain, but there was a really considerable difference of people with severe pain. So what's interesting about this is that, number one, this is looking at cannabis in its whole form. So people are getting all of the different cannabinoids that were in the plant and all the terpenoids, which is something that you're not getting in some of those other studies where they're just using the synthetic products. So oftentimes people ask me about cannabis as a potential cancer cure. They've read various things on the internet, including about Rick Simpson, and that he claims that if you use a specific cannabis type of recipe, that you may actually be able to cure your cancer. But when it comes to actual research evidence, there's extremely limited what we call preclinical evidence. Preclinical evidence is, the terminology is in vitro or in vivo, and that basically means either in a laboratory setting, test tube type setting, or maybe in a rodent model, an animal model. And one very small study was done in humans, and it wasn't a study to look at the effectiveness of cannabis against cancer. It was only to look at if we increase the dose, do people have any safety concerns or serious or severe adverse effects? And that was in patients with a certain type of brain tumor, where they actually, in the area where the brain tumor was removed, they put various dose quantities of THC in that area, just to see if they had any major safety issues. And because a few people did significantly better than was expected as far as life expectancy, a lot of people have kind of hung their hat on that information, feeling like, gee, this might mean that cancer can be cured. And so there's potential here. There are studies looking at certain cell lines like pancreatic cancer cells, breast cancer cells, again, possibly in test tube form, possibly in an animal model. But we really don't have data in humans that's strong just yet to say that we should be using any particular type of cannabinoid or quantity, and that it could be any certain cure. So I think that's really important to know, that we need a lot more research before it would be reasonable to try utilizing cannabinoids as a treatment modality. So I want to also talk about cannabis administration routes. So this is a switch over a little bit now from evidence to how the medicine is taken and what you really ought to know about that, so that you can make informed decisions if you're choosing to use it, how you want to use it, etc. So this is something I think is one of the most important things to talk about. And so basically there's several forms. There's inhalation, there's absorbing it through the oral tissue, also called the mucosa, through the GI tract, or absorbing it through the gut. This is when something is taken in an edible form or a capsule and swallowed, through the skin, and also through the rectal mucosa via suppository. And so there's different onset and duration, and this is one of the things I like for people to be aware of, is that if someone is using an inhaled form, whether smoking or using a vaporizer, the onset of that is very quick and the duration is fairly short. But oftentimes people are interested in using edibles or capsules. That feels more like medicine, or it feels more natural. But you have to be wary that the onset could be between 1 and 3 hours. And what that can lead to is, if you take an edible product and you don't think you're feeling something, and you're not aware that you might need to wait the full 3 hours, you might end up taking more and more until you've taken a quantity that makes you very uncomfortable, and then it's going to last for quite a long time, 6 to 8 hours. I do want to make some notes in terms of the skin delivery or via suppository. There's a lot of variation in onset and duration, but a couple of notes. It is thought that using vaporizable medicinal products may be less harmful than actually doing smoking via, say, like a cannabis cigarette type of form. Also, very little is known about what I would say is non-prescriptive oral mucosal delivery systems, sprays. Nabiximols was very well researched, again, not available here, but utilized in Europe and Canada. But here, what we use for delivery through the mucosa or the tissue in the mouth are tinctures, lozenges, sprays. And those can have a pretty quick onset, still a fairly high duration, which may be good for helping with certain symptoms. Bioavailability, or the availability of the medicine part of cannabis when taken through the gut, in addition to having this really wide range of onset and duration, long duration. Some people can absorb a really small amount, some people can absorb a really large amount. So you have to kind of play with that to figure out what works for you and what your experience is. Skin applications, creams, ointments, patches, typically are not going to get into the bloodstream and be terribly systemic, meaning they're not going to give you the all over effects. They tend to be local effects. So for some people that's very comfortable, but there's very limited research on that, so we don't know a lot. And then finally, suppository use. There's a specific form of THC, and this is what it's bound to, that appears to be best absorbed via the research, but I don't know that very much of that type of product is available on our medical market. So some cautions, and I apologize, I'm not sure why the slide set here got a little weird, but there are products called dabs, which are volatile concentrates. That people may use, really are used more recreationally and are inhaled products. They can be extracted via various solvents, liquid gases, or CO2. Believe it or not, CO2 is actually the safest mechanism of extracting cannabis for use, whether in a vaporizable product or a tincture. Certainly solvents can be really bad for you, things like hexanes, and liquid gas like propane or butane. We don't want to take those into the body. So it's worthwhile noting that studies looked at some of these products and found large numbers of samples of these particular types of things having residual solvents, also sometimes pesticides, including one not listed for use on food crops. And it's been said that volatile organic concentrates, again, these are typically recreational products, are best avoided for medical use. Also important to know that even if you're using whole cannabis and considering using that in an inhaled fashion, whether via a low temperature vaporizer or smoking it, bacteria and molds do grow on green bud, and there have been a few cases of aspergillus, which is a fungus that can be fatal, and people getting that via the inhalation route. There are studies showing that cannabis can be sterilized against bacteria and molds, but I don't know that it's something that's happening just yet in the US. It's also important to know that for the digestive tract, there's something called first pass metabolism. So when you take either an encapsulated product or a food product and it's absorbed in the stomach area, the first place all the medicine goes is to the liver, which then metabolizes THC into a different product termed 11-hydroxy-THC. This is the chemical term. And it is a very potent psychoactive, and it also reduces the bioavailability of THC, which is the medicine you're looking for. So this can really cause an increase in the high effect that some people don't want to experience. And also because of the bioavailability and the difference in how much you might absorb, which varies from person to person, can be really hard to determine the dose of this. Further cautioning for the digestive tract, there are a lot of labeling inaccuracies that have been identified. So content analysis of several edible products from the Seattle and California areas were looked at, and 23% of these products were under-labeled, meaning that they actually contained quite a bit more THC than they were labeled for. So somebody expecting a certain quantity, like 5 milligrams, may be getting quite a bit more, and that can lead to difficulty in dosing or potentially overdosing. So I think it's important to be aware of that. In the state of Washington, they now are actually required to have very accurate testing, but I think it's worthwhile to note that that may not be the case in all states where people get medical cannabis. And in terms of suppositories, I think the one thing is that if people are actively undergoing chemo, it's important to know that typically oncologists will tell patients not to use even regular suppository medication while they're getting chemotherapy because of the risk of infection. So I think that's important information too. Next, I want to get into contraindications and potential adverse effects. So reasons to not use cannabis at all would be, of course, if you have an allergy to cannabis itself or to any of the vehicles that the cannabis would be delivered to you in. So for example, even the medical version of cannabis, the dronabinol, is delivered via sesame oil, because cannabis actually is what we call lipophilic or fat loving. So it likes to be delivered via a vehicle of some type of oil or fat substance, fatty substance. So if you were allergic to sesame oil, it would not be a good idea to take your cannabis via dronabinol. Pregnancy and breastfeeding, not a good idea. Still, cannabinoids can actually, cross over the placenta and into breast milk, so we don't recommend it at that time. Active heart or respiratory concerns, also active liver or renal function issues would be reasons to not use cannabis. And then finally, there are concerns for people who have a mental health history of things like schizophrenia, bipolar disorder, or depression, because at times studies have suggested that these conditions can be made worse with cannabis, as attempting to use it recreationally or even medically. If you have a history of heart conditions or angina or high blood pressure, asthma, or chronic obstructive pulmonary disease, you also should really be very cautious if you're wanting to try using cannabis. And so to let you in on some of the adverse effects, I think it's important to be aware that the most common adverse effects or unwanted effects include drowsiness and fatigue, dizziness, anxiety, nausea, cognitive effects like confusion, disorientation, hallucination, and memory issues, short-term memory issues. And then also if inhaling it, then coughing, phlegm, production, bronchitis. And then also common, although not as common, euphoria or the high feeling that you get, which some people question whether that's really an adverse effect, but blurred vision and headaches can occur. And then much more rare, but often talked about, are hypotension or low blood pressure, psychosis or paranoia, really rapid heart rate, hyperemesis or an increase in vomiting, significant amount of vomiting, again, very rare, but also diarrhea and loss of coordination. So there's also some cannabis drug interactions. There are certain drug effects that can be increased if they're used at the same time as THC in particular. So this would be alcohol, benzodiazepines, things like Ativan, Xanax, and also opiate medications, codeine, fentanyl, morphine, and opiate pain medication. So it's important to know that if you are taking those medications already, you're thinking about using THC, these things can increase particularly the sedation effect of those medicines, and you need to be cautious or possibly at least cut back on some of those medicines if you're trialing THC. And then CBD has very few known drug interactions, but with one of the benzodiazepines called clobazepam, it can potentially increase the sedation, and that would be a medicine that would have to be dose reduced. So a little bit about dosing. So all of the experts that talk about cannabis use as a medicine say start low, go slow, and stay low in the dose. This helps limit the fatigue, the high heart rate, the dizziness that you can experience, and it aids in somebody developing a tolerance to the psychoactive effects. It's also recommended that you consider a type 2 or a type 3 chemovar. So a type 2, again, is THC and CBD in near equal quantities, so percentages. So for example, if a cannabis product is 20% THC, it should be very near 20% CBD. Or a type 3, which is primarily CBD with far less THC. Again, remember that the CBD has that synergistic effect of tempering unwanted THC effects, primarily the psychoactive effects that people don't like feeling when they're taking this as medicine. For chronic issues, once people are kind of accustomed to dosing and side effects and maybe the psychoactive effects, orally ingested products could be a mainstay of treatment, particularly for pain, since they last so much longer than a product delivered via the oral tissue or inhaled. Of course, I say this is if you're tolerating it, because again, when you take a product via ingestion, you get quite a bit more of that psychoactive 11-hydroxy THC, and some people aren't comfortable with that. And then again, and these are physicians who would say that acute or breakthrough type symptoms, vaporization could be useful, and there are vaporization products or vaporization devices that can vaporize whole green bud at very low temperatures, so you're not getting a lot of the toxic byproducts from actually burning something with a flame, but you're just getting you're just volatilizing the THC and the terpenoids and breathing in just that. Further, so starting and increasing, and again, this is per McCallum and Russo. Dr. Ethan Russo is a local Washington physician who's been researching cannabis for over 20, probably, gosh, I'm going to say, yeah, over 20 years. Very well published and peer-reviewed literature. And they suggest that initially starting a THC type product, you would start it at bedtime, and for the first couple of days, use a very low dose. 1.25 to 2.5 milligrams, even lower if you're over 65. And if tolerating that dose, you can increase slowly every few days until you reach the desired impact on your symptoms. If daytime use, they would say, 2.5 milligrams of THC, again, increasing every few days by 2.5 milligrams. Up to taking it up to about 3 times a day. They suggest that you want to increase very slowly towards 5 milligrams 3 times a day. That should be optimal, and you really shouldn't need too much more than that. And if you include CBD in whatever product you're taking in an equal amount, it will reduce those unwanted psychoactive effects. And then finally, they have found in the research that more than 20 to 30 milligrams in a day increases the side effects without really improving desired effects of cannabinoids, THC particularly. CBD, we don't have as much dosing guidelines for this. There are quite a bit fewer side effects. It's not quite proper to say that it has no psychoactive effects because it can reduce anxiety. So technically that is a psychoactive effect, but it doesn't have the paranoia, hallucination, memory issues, disorientation that THC tends to. There may be a benefit of having 5 to 20 milligrams per day, dividing that into twice a day or 3 times a day dosing. Here's an example. And possible interaction, again, benzodiazepines, Ativan, Xanax, things like that, could really be increased as far as their sedative effects if you're using really large quantities of CBD. Most people shouldn't need to use in the neighborhood of 400 milligrams. That tends to be used more for seizure control. And finally, you really shouldn't drive. That's probably one of the most important things if you're going to use cannabinoids, that you're not driving while they're actively influencing you. So of course the officer here has pulled people over saying, "I couldn't help noticing you were driving exceptionally well." And the fellow says, "Hide the dope, Frank, he's on to us." So in summary, cannabis has a very long history of medical use and may be effective for some conditions. Pros and cons include differences in effects, contaminants, and such, and then the best dose, figuring it out that it's the lowest for relief with good tolerance. And then here's some resources for you.